Today, our first speaker is Farah. She's a medical officer. She was in the Division of Cancer Treatment and Diagnosis. Now she's in the Center for Cancer Research, the Women's Malignancy Branch. She got her MD at George Washington University Medical Center and then was a staff fellow under Sandy Swain, where she learned all about breast cancer. And she's going to talk to you today about breast cancer, an overview and treatment options in the genomics era. Farah.
Thank you, Terry. Okay, so I always like to start my talk by talking a little bit about statistics because it'll give you an idea of all of the progress that we've made in breast cancer over the years. So in 1975, the incidence rate for female breast cancer in the US was 105 new cases diagnosed for every 100,000 women. The mortality rate at that time was 31 deaths. And then from 1975 to 1977, of those diagnosed with breast cancer, about 75% survived their disease about 5 years. Among white females, the relative survival rate was 76%, and among African Americans, it was 62%. In 1975, mastectomy was the only accepted surgical option for the treatment of breast cancer. There was only one randomized trial of mammography for breast cancer screening that had been completed, and several other trials were just beginning. Clinical investigations of combination chemo using multiple drugs with different mechanisms of action and of hormonal therapy as adjuvant treatment were in its earliest stages. Then in the mid-1970s, clinical investigation of the drug Tamoxifen as a hormonal treatment of breast cancer was just beginning. In the 1970s, there was no gene as of yet that was associated with an increased risk of breast cancer. For the years 2009 to 2013, the incidence rate for female breast cancer was 125 new cases diagnosed for every 100,000 women, and that was up from 105. The mortality rate was down from 31. It was 21.5 deaths for every 100,000 women. And the 5-year survival rate was 92% for white females, which was increased from 76%, and 81.5% for African Americans, which was increased from 62%. So from the years 2007 to 2013, the survival rate remained pretty steady at about 90%. And for the year 2017, we estimate that there will be 252,000 new cases of breast cancer, and there will be approximately 40,000 deaths. Here you can see that the incidence rate has been slowly rising over the years, which can be attributed to increased screening among women age 40 and older and better early detection. The breast cancer death rate or mortality rate in the US has been declining steadily since 1989, where it peaked at a rate of 33 deaths for every 100,000 women. And at the very bottom, you can see that the survival rate has also been steadily increasing. So these are interesting numbers. So looking at incidence and mortality by race, the red line represents white females, the blue line represents African American females. And for African American females, the incidence rate rose sharply from 1975 to 1990, and then it reached a plateau. And for white females, the incidence rate has always been higher than African Americans. It rose sharply between 1980 to 1985. And then more recently, it has declined and reached a plateau. And at the very bottom, you can see that mortality has been declining for both African American females and for white females, but it has always remained higher for African American females. So how can the increasing incidence and decreasing mortality results be explained? So a study was done using the SEER database to estimate the incidence rates, mortality rates, and survival from breast cancer for white females between 1975 and 2011. mortality rate decreased by 28%, while the incidence rate actually increased by 30%. So it was further determined that the increased incidence was mostly represented by the localized breast cancers, which were likely resulting from an increased screening, push for screening. From 1975 to 2002, the 10-year survival rate increased by 28%, but it was noted that the increased survival was greater for regional cancers than for either localized or distant cancers. So this study, looking at the SEER database, determined that the decline in breast cancer mortality during this time period was not specifically due to early detection, increased diagnosis from screening, but rather it was due to the improvements in chemotherapy, hormonal agents, the schedules that we use, and a gradual expansion in the number of women who were candidates to receive these therapies. So we are making progress in our research and our treatment. So let's talk about breast cancer. The structure of the breast, it's composed mainly of fatty tissue, and it contains a network of lobes that are made up of lobules that contain milk glands, and then these are all interconnected by a ductal system. And also within the breast, there are blood vessels and lymph vessels that run throughout. And about 90% of all breast cancers start in either the ducts or the lobes of the breast. So we don't really know exactly why women develop breast cancer. We do know, though, it's a combination of genetic factors, environmental factors, and lifestyle factors. Definitely, we know that hormones seem to have an important role. Research has shown a link between estrogen levels and the risk of developing breast cancer. So here are some of the common risk factors. Age is definitely a risk factor. 80% of breast cancers do occur after menopause. If a woman has had a prior history of breast cancer, that definitely puts her at an increased risk for another breast cancer. If a woman has had a history of hyperplasia, which is the ducts lined with too many cells, not necessarily atypical cells, but just too many cells to begin with, or a carcinoma in situ when those cells are actually atypical, cancerous, that also predisposes to an invasive cancer later in life. Also, exposure to excess endogenous or exogenous hormones by means of an early menarche or a late menopause can do it as well. And use of hormone replacement therapy, which based on the Women's Health Initiative, we do not do that anymore. But there are women who've had it in the past. The Women's Health Initiative study was in the early 2000s that showed the risk between estrogen and breast cancer. Also, if somebody has had no pregnancies until the age of 35, that will expose her to more estrogen and is a risk for breast cancer. Women who have a history of breast biopsies are at increased risk, and it's not the biopsy itself that puts you at the risk. It's just the fact that these women seem to have a predilection to lesions that are of concern that could eventually later be a cancer. Also, radiation exposure before the age of 40. For example, there are case reports of women who have been treated for Hodgkin's lymphoma with radiation and develop breast cancer later in life. Finally, the last two, if you are told that on mammogram you have dense breast tissue, that has been correlated with an increased risk of breast cancer. And lifestyle factors, including alcohol, lack of exercise, and obesity. So we know that family history is a very important risk factor. If your mother, sister, or daughter has developed breast cancer before menopause, you are 3 times more likely to develop the disease. If 2 or more close relatives have had breast cancer, you're also at increased risk. Genetics is also very important. Breast cancer has been linked to mutations in multiple genes, as you see here. BRCA1 is associated with familial breast and ovarian cancer, BRCA2 with male and female breast cancer. Mutations in P53 and RB1, which are tumor suppressor genes, also can predispose to breast cancer. P53 is very common in triple negative breast cancer, which is a aggressive form of breast cancer. Amplification or mutations in the oncogenes also can predispose to breast cancer. Women who have mutations in both P53 and BRCA1 have a lifetime risk of breast cancer of 85%. And most often this is triple negative breast cancer, as I said. So October is early detection month, so I feel compelled to talk about early detection and screening in my talk. So mammograms can be used as screening tools to detect early breast cancer in women who are experiencing no symptoms. Mammograms can also be used to detect and diagnose breast disease in women who are having some symptoms or have felt a lump or seeing a nipple discharge. Oftentimes, an ultrasound can follow the mammogram to clarify the concerning area if a lesion is found. Sometimes areas can be non-malignant. They can be fluid-filled cysts, which can be further clarified using an ultrasound. We know that mammograms reduce mortality by 26% for women who are between the ages of 50 to 74 and 17% for those who are between 40 and 49. So what are the American Cancer Society guidelines? So for women who are at average risk, for those who are aged 40 to 44, these women have the choice to begin mammograms, and the risks and benefits should be considered. The risks, of course, are procedures and biopsies that are not necessary because lesions that are not malignant may be picked up. And the benefits would be clearly to detect early cancer. Between age 45 to 54, annual mammograms are definitely recommended. 55 and older, they can switch to biannual, or have the choice to continue an annual schedule based on family history or other risk factors. And the screening should continue for as long as the woman is in good health. So women who are at a higher than average risk, and this will define women who have a lifetime risk of breast cancer of greater than 20 to 25%, using risk assessment tools based mainly on family history. Those who have a known BRCA1 or BRCA2 gene mutation, or have a first-degree relative with BRCA1 or BRCA2 gene mutations, but they personally have not had testing themselves, so they need to keep up with mammograms. Or if they've had radiation to their chest between the ages of 10 to 30. So for these women, the American Cancer Society guidelines recommend an annual MRI and a mammogram as long as the woman is in good health. So what about the use of MRI for early detection? So while MRI is definitely more sensitive than a mammogram, it also has a higher false positive rate. So this may lead to unnecessary biopsies and other procedures. Therefore, the American Cancer Society recommends against the use of MRI for women whose risk is less than 15%. But for women who have a moderately increased lifetime risk of breast cancer, there is not enough evidence, again, to make a recommendation either way. But if MRI is used, it should be in addition to and not in place of a screening mammogram. Okay, so what does the American Cancer Society guidelines say about clinical breast exams and the self-breast exam? So there is no solid clinical trial evidence that a physical breast exam done either by a healthcare professional or by the women themselves provides any clear benefits in early detection or reducing breast cancer mortality. So due to this lack of evidence, regular clinical breast exams and self-exams are not part of the ACS guidelines. But definitely all women should be familiar with how their breasts look and feel and report any changes to their physician. So guidelines are based on statistics that apply to statistical benefit that applies to a large cohort of patients. But when you look at the individual patient, definitely self-breast exams are important. So we as physicians do recommend self-breast exams, despite the fact that they're not included in the guidelines. Guidelines are based on evidence. Evidence is based on statistical benefit to a larger group of people. So just since it is Breast Cancer Awareness Month, I just want to put this up here and have you see the steps. So women should take a look at themselves in the mirror with their arms elevated, arms to their sides, and they're looking for changes in size, shape, color, dimpling, puckering, inverted nipple, or nipple discharge. Then you want to feel your breast both lying down and standing up. And you want to use a firm, smooth touch. You want to use fingers flat and together using a circular motion. And you want to follow a pattern. And it doesn't matter what pattern, but you need to cover your whole breast. The abnormal signs and symptoms, as you can see, common sense, any changes in size, tenderness, redness, change in nipple position, scaling around the nipples, soreness, puckering, dimpling, retraction, nipple discharge, thickening of the skin, or a retracted nipple. Okay, so the diagnosis of breast cancer is definitely a journey that begins when an abnormality is detected, either on breast self-exam by the doctor or on some imaging study. So after something is detected, the patient the next step would be to find out whether if it's malignant or not malignant. So there are two procedures that can be used, either a fine needle aspiration using a syringe. Cells will be withdrawn from the lesion and looked at to see if it's cancerous, or a core biopsy can be done, which is actually they use a device to take a piece of tissue and look at that tissue. So then they come up with a pathological diagnosis. If it's cancer, the patient will be referred to the surgeon. The procedures the surgeon may recommend could include lumpectomy, which is excision of the lesion itself with wide, clean margins. The reasons why a patient may not be able to have a lumpectomy would be if they have a large lesion and a small breast, so cosmetically it would not be possible. And a wire localized excision is done in cases where the lesion is not palpable, so a wire is placed in the lesion using imaging techniques, and then the surgeon knows exactly where to go during the surgery. The mastectomy is the other option to take off the breast. However, keep in mind, having a mastectomy does not completely prevent a recurrence because all of the tissue cannot be taken off. There's always some that's left behind. The surgical techniques also involve lymph node operation. A sentinel lymph nodes would be the first draining nodes, or the axillary nodes, or the full set of axillary nodes in the axillary chain. And I'll talk more about that. So here's the structure of the breast, the lymph nodes that are important in breast cancer, those that are above and below the clavicle, the axillary chain, the mediastinal chain, the internal mammary chain, and then there's the single interpectoral Rodder's node. So the axillary dissection is the traditional procedure for staging breast cancer. It involves removing 10 to 30 lymph nodes in the armpit closest to the tumor. Of course, the benefits are that all of the lymph nodes can be examined for cancer, and it's a reliable determination of if the cancer is spreading. But the drawbacks definitely are post-surgical complications that include lymphedema, infection, and nerve damage. And a lot of patients actually, infection and nerve damage maybe not so often, but lymphedema is definitely a problem. So a sentinel node biopsy, which is more recently done, it's a less invasive method to determine if axillary nodes contain cancer with fewer complications. It is the current recommendation for patients with early stage breast cancer who are clinically node negative. That means if the physician is not able to actually feel the lymph nodes on exam. So during surgery, isosulfan blue and or technetium-99 is injected near the tumor or under the nipple. The tracer and the dye travel to the lymph node, and the sentinel node is the first node that actually gets the drainage. And then the surgeon will remove either the first node or the cluster of 2 or 3 that get the drainage. If the sentinel nodes are clean, then more than likely the rest of the axillary chain is clean, and so those other lymph nodes will be left intact, hopefully preventing women from getting lymphedema and the other side effects and problems with lymph node dissection. So after the surgery, you will get the final pathology report that includes all the biomarkers, and you'll know how many lymph nodes are positive. The patient will go back to the surgeon, and then they will get a referral to the medical oncologist and radiation oncologist, and further decisions about the treatment are made. So breast cancer staging, so once a diagnosis is established, the physician needs to actually stage the cancer. Staging is a way of describing a cancer, such as the size of the tumor and where it has spread. It is one of the most important diagnostic tools that we have. Even with all of the new things that we are using these days, this is really a basic tool. We use the physical exam and CT scans to further stage the patient and see where the cancer is. I'm not going to go through this. It's in your handout. These are the stages, and so you can take a look at that. And then just briefly, developing cancer is a spectrum of going from normal cells to an invasive cancer. A normal duct will have a single layer of epithelium, and then a hyperplasia is normal cells that are just too many of them. Then you can have atypical cells that are not quite right, and then a ductal carcinoma in situ is actually a malignancy within the duct, but it has not invaded the rest of the breast yet. And finally, when the cancer breaks through the basement membrane of the duct of the breast, it gets into the fatty tissue, can get into the lymph nodes, and it can spread from there. Inflammatory breast cancer is a little bit different. I'll just talk briefly about that. Here you have malignant cells that infiltrate and clog the lymphatic vessels in the skin of the breast, which are the dermal lymphatics. The blockage in the lymphatic vessels causes red, swollen, and dimpled skin, and that's the classic sign of inflammatory breast cancer. These are the guidelines for diagnosis. You need a minimum criteria for inflammatory breast cancer. You need a biopsy from the affected area showing invasive carcinoma, and you also need a clinical history of rapid onset of erythema, edema, and a podorange appearance, which is like the skin of an orange. Also you can see abnormal breast warmth, and you don't necessarily have to see a lump. So this is what makes this cancer different. So sometimes symptoms can be less than 6 months, although there's often misdiagnosis with this. Erythema covers at least 1/3 of the breast. And these are the minimum criteria for diagnosis of inflammatory breast cancer. This is actually one of my patients from some years ago, African-American female who had inflammatory breast cancer. So here you can see the peau d'orange look to the skin. It looks like an orange peel. In the African-American women, you cannot necessarily appreciate the erythema, though. And you see the swelling. The breast looks bigger, it's swollen, but you don't appreciate the erythema. These are also pictures from some of my patients who've had different presentations of inflammatory breast cancer. As you can see, there's a variety of presentations, and unfortunately, sometimes they can mimic an infection. And if the patient goes to her primary care physician, many times it goes misdiagnosed and can be treated with antibiotics for a while before somebody realizes that this is not an infection. And by that time, it's just too late. So what are some of the prognostic and predictive factors influencing treatment decisions? So the treatments that we have for breast cancer include surgery, radiation therapy, chemotherapy, hormone therapy, and targeted therapies. And the selection, how we select our therapies, is based on many things that include the patient's menopausal status. So a lot of our hormone therapies will depend whether a patient is premenopausal or postmenopausal. We also look at the stage of the disease, the grade of the tumor, how aggressive pathologically it is. We look at the hormonal status to see if we can use hormone therapy. We look at HER2 new amplification to see if we can use targeted agents to the HER2 new protein. We look at the histological subtype of the cancer. There are some that have a more favorable histology and others that are more aggressive. Also, we look at the patient's age and general health. And then more recently now, we have molecular profiling, and we look at the presence of mutations. And I'll talk more about that. These are just for you to see. These are some of the common chemotherapies that we have that are used to treat invasive ductal carcinoma. And so this is showing the absolute risk reduction of relapse and mortality with polychemotherapy over single agent chemotherapy. So when you are, for patients who have early stage breast cancer, we are treating them to cure them. So we know that treating with more than one agent is more beneficial than treating with a single agent. So we definitely want to use everything we can to cure people before the cancer has spread. So both age groups, we can see this graph is showing that both age groups do benefit from polychemo, but the greatest reduction in recurrence and mortality is in those that are less than 50. These are just some examples of the combination chemotherapy regimens that we have. You can take a look at that. Adriamycin and Cytoxan is followed by paclitaxel or Taxotere is one of the very common regimens used for a long time. And you can just take a look at that. These are examples of the hormonal therapies that have been approved for early stage and locally advanced breast cancer. Tamoxifen, it blocks estrogen at the estrogen receptor. Anastrozole, Arimidex. I mean, these are aromatase inhibitors. In the postmenopausal women, they block the production of estrogen from androgens in the adrenal gland because that is where the majority of estrogen is produced in the postmenopausal women. So So tamoxifen as an adjuvant treatment. So this is a key study that was published in Lancet Oncology in 2005. It's just basically showing that those patients that are hormone receptor positive, they derive a clear benefit in both recurrence and mortality when you add tamoxifen to their regimen. 5 years of tamoxifen is greatly beneficial. Then with the advent of aromatase inhibitors, as I mentioned, there's been some question in the postmenopausal women. So what do we do? Do we just give the postmenopausal women tamoxifen, or do we sequence it with an aromatase inhibitor? So many studies have been done, and clearly there is benefit in recurrence, as you can see from the first graph, when you add an aromatase inhibitor to the sequence. But mortality, there's less of an advantage. These are examples of targeted therapies. The first two target HER2, and lapatinib is a tyrosine kinase inhibitor. We also have MTOR inhibitors. We have palbociclib, which is a CDK4/6 inhibitor. The last one, adotrastuzumab amantacine, is a combination of Herceptin plus amantacine. And amantacine is a cytotoxic chemotherapy, so they basically link the two together, and Herceptin targets the chemo to the HER2 positive cancer cell. And so we're actually doing a clinical trial in our group. I can talk more about that later. So how do clinicians make well-informed decisions about which patients to treat with chemo and what to choose? We use the basic criteria as we always have for many years: tumor size, molecular subtype, histology, pathological grade, nodal status, hormone receptor status, the patient's age, comorbidities, performance status, and these things have been used for the longest time. But now we're using gene expression profiling of the primary tumor to predict the response to particular agents. And we're also using gene expression profiling to predict and treat only those patients who are most likely to recur and who will benefit the most from chemotherapy. So these are the two ways that we are using gene expression profiling in breast cancer treatment. So what are genomic tests? The difference between genomic and genetic tests, a lot of people ask that. So genetic testing involves sequencing a person's DNA. However, in the context of cancer medicine, genomic testing identifies the abnormalities that dictate how a patient's tumor behaves. So the last decade has witnessed the emergence of genomic profile assays of primary breast tumor that allow for better risk prognostication and predictive benefit of adjuvant chemotherapies, as well as giving us information on the likelihood of a cancer recurring and metastasizing. So this was the landmark paper that started the molecular profiling in breast cancer. This is the study by Sorley that was published in PNAS back in 2001. And this was looking at gene expression patterns of breast carcinomas. And based on the expression patterns of 85 samples that they analyzed, they were able to classify breast cancer into 6 different subtypes. And the subtypes actually behave all very differently, and they have different prognosis. So here, so they were trying to see whether those different subtypes do correlate with prognosis. And so they did a survival analysis on a subcohort of patients with locally advanced breast cancer, and all of those patients had been treated in a study showed they were treated in the same fashion, and they showed significantly different outcomes for the different groups. And it seems that luminal A subtype appears to have the best prognosis, and basal-like seems to have the worst prognosis. So this is showing you gene expression arrays that can categorize breast cancer by molecular subtype, and they can inform prognosis and therapeutic response. So those that are luminal A, it seems we now know that those are hormone receptor positive, they're low grade, they have a more favorable outcome. Those that are basal-like, they usually have P53 mutations, they're more often triple negative, they're high grade, and they have a poor outcome. So the classifications established by the Sorley study definitely correlate with prognosis and therapeutic response. So this is a schematic representation of the most common biomarkers that are used to stratify and treat breast cancers. So once you have an invasive breast cancer diagnosis, if the patient qualifies for germline testing based on family history, they will get BRCA1 and 2 germline testing. If they don't qualify for germline testing, they will get a histopathological evaluation of their tumor, which includes standardly ER/PR, HER2/neu. It includes Ki67, which is a nuclear protein that is indicative of proliferation rate. These days, we're looking at PDL1 in some instances, which can predict for immunotherapy responses. And in some instances, we are getting multi-gene sequencing assays and gene expression arrays, and I'll talk more about that. So this, the table shows you a summary of molecular tests commonly used for breast cancer that are in current clinical practice. So next-gen sequencing has made it possible to sequence large numbers of genes to identify actionable mutations. And so clinically actionable mutations are those that are either prognostic, that is, they correlate with the behavior of the tumor irrespective of any therapy, or they are predictive. They correlate with a response to a therapeutic agent. And some mutations may be pathogenic, that is, that they are driver mutations without being specifically actionable. So the MemoPrint is an FDA-approved 70-gene breast cancer recurrence assay that is currently used in practice. It is a tissue-based genomics test which uses microarray technology to analyze a patient's breast tumor biology to predict which cancers are more likely to recur and to metastasize. So this was approved by the FDA back in 2007. So it's validated for patients who are stage 1 or 2. They have an invasive cancer, tumor size less than 5 centimeters. They're lymph node negative, ER either positive or negative, and HER2 either positive or negative. So for the development of this assay, the researchers wanted to answer the main question, who is at risk for recurrence? So this is a very important question because this is what we base our treatment recommendations on. So tumor specimens from 78 untreated breast cancer patients with known outcomes were analyzed. The entire human genome was interrogated to determine which genes were most predictive of recurrence at 5 years, and they were able to identify 70 genes. And very importantly, this test actually interrogates all 7 genomic pathways of the metastatic cascade. So that's important. So multiple studies have actually validated this assay. One of the key studies was the Transbig study published in 2006. They found that this assay was able to appropriately stratify patients into binary classifications of either high or low, with statistically significant difference in the probability of metastasis-free survival at 10 years. So those patients that this assay categorizes as low risk have a 10% chance of recurrence at 10 years without any adjuvant treatment. And this assay, for those patients who are classified as a high risk, they have a 29% chance of recurrence at 10 years if they do not get any adjuvant chemo. So another study was published in 2010. It validated the predictive value so the first study validated the prognostic value. This study actually validated the predictive value of this assay for adjuvant chemotherapy. So for those patients that this assay classified as low risk, it seemed that there was no statistically significant benefit to adding chemotherapy. And for those patients who were classified as high risk by this assay, there was a 12% absolute benefit to adding chemotherapy. And this is very important information because we certainly don't want to expose women to unnecessary chemotherapy. There is toxicities associated with all chemo, and it's not necessary to just give chemo to everyone. We need to have a better understanding of who would be at benefit. So these genetic profiling tests are very advantageous. So the Oncotype DX is a molecular assay that we are also using in clinical practice. It is a prognostic test in that it provides information about how likely or unlikely the breast cancer is to come back. It is also a predictive test in that it predicts the likelihood of benefit from chemo or radiation. And so this is the feature that makes it stand out from the previous test that I talked about. So the way this test was developed, an RT-PCR method was designed to quantify gene expression and prognostication. It was initially actually validated only for ER-positive, HER2-negative, node-negative cancer, but now it's been actually extended to node-positive disease as well. So 250 candidate genes were selected from the literature, genomic databases, and on a variety of experiments based on DNA microarrays. And then those with prognostic significance were identified using 3 independent clinical studies of breast cancer involving 447 patients to test the relationship between the expression of those genes and the recurrence of breast cancer. So finally, they came down with 16 cancer-related genes, and those genes fell into 3 groups that were related to proliferation, ER, estrogen receptor, and an invasion-related group. Then they had some miscellaneous genes, and they had 5 reference genes. Then they developed an algorithm based on the levels of expression of these genes, and they computed a recurrence score for each tumor sample being tested. So then they validated the prognostic value of the Oncotype DX. This was a key study published back in 2004. So based on retrospective analysis of tissue samples from another study, the B14 study, the assay and the recurrence score were validated as quantifying the likelihood of distant recurrence. And these patients from the B14 study were tamoxifen-treated patients with node-negative hormone receptor-positive disease. So for those patients, based on the Oncotype DX, if they were put into the high-risk group, they were able to correlate that with a high distant recurrence rate. And for those who were put into the low-risk group, based on this test, they actually did have a low distant recurrence rate. So the test was validated. The Oncotype, this is also a key study that was published in JCO. And this study validated the predictive value of this assay to predict the benefit from chemotherapy. So patients with tumors that have a high recurrence score have a large absolute benefit of chemotherapy. And patients with tumors that have a low recurrence score, they derive minimal benefit from chemotherapy. So the tests have been validated. So the Taylor X, so studies have validated that the 21 gene Oncotype DX assay that has been converted to a recurrence score is predictive of response to chemohormonal or hormonal alone treatment in patients with hormone receptor positive, node negative disease. It is clear that patients with a high recurrence score benefit and those with low recurrence scores do not. But the gray zone is definitely those patients who have a mid-range score. What do we do with those patients? Do they get chemo? Do they not get chemo? What do they do? That's a big question. So the Taylor RX trial was designed to answer that very question. And of course, our goal as clinicians is to spare the toxicity of chemo in women who don't need it. So the Taylor RX trial using patients with stage 1 or 2, hormone receptor positive, node negative, HER2 negative patients. So they got the Oncotype DX assay, and those who have a high score, they would receive chemo plus hormone therapy. Those with a low score will get hormone therapy alone. But those with the mid-range score, and this is the primary study group for this particular trial, they're divided into hormone therapy versus the chemo plus hormone. And we do not have the results from that very important primary study group yet. However, for the low risk cohort, they did report that in September of 2015. And so for women with a recurrence score of less than 10, hormone therapy alone is an effective choice. And the study supported the clinical validity of the gene assay in identifying patients who may be spared the toxicity of chemo. But we're still awaiting the results of the patients who have a mid-range score. So what are the clinical implications of molecular diagnostics in breast cancer? So treatment is definitely becoming more personalized for patients. Physicians continue to understand the disease itself, as well as advancement with genomic testing that definitely will lead to more optimal treatment plans. Next-gen sequencing is now increasingly being used to identify potentially actionable mutations in tumor tissues. The Cancer Genome Atlas study published in Nature profiled 500 tumors and found that about 10% of all tumors had more than 6 mutations. Most tumors either had no mutations identified in the top 40 cancer-related genes or only had a few. Specifically in breast cancer, there are not as many mutations in cancer-related genes as may be seen in other tumor types. So therefore, in terms of research, a key area right now is definitely profiling of metastatic tumors to get a better idea of the mutations that are important in this disease. There are still a lot of things that need to be worked through. For example, if a specific mutation is found, we don't know whether it's a driver or a passenger. And again, these are things that need to be worked out. So what are the current guidelines for genetic testing? The biomarkers we always test for in breast cancer are ER, HER2, and perhaps BRCA. And now, since we are more interested in identifying BRCA mutations, it is recommended by national guidelines to sequence the BRCA1/2 genes in patients who have triple-negative breast cancer. Next-gen sequencing is not recommended as standard of care yet in breast cancer. However, it is done whenever possible, especially at the major academic institutions, and the goal, of course, is to direct these patients to clinical trials. So here at the NCI, we have the MPACT trial. It's a molecular profiling-based assignment of cancer therapeutics. The purpose is to assess whether assigning treatment based on specific gene mutations can provide benefit to patients with metastatic solid tumors. During the screening process, samples of tumor from patients with various cancers are genetically sequenced to look for different mutations. And so if mutations of interest are found, then those patients are enrolled in the trial and they're assigned to either treatment arm A, which is targeted therapy, or treatment arm B, which is non-targeted therapy. If they are assigned to arm B and they progress, they can cross over and go to the targeted therapy. So what we don't know is whether using this approach is really effective at providing clinical benefit. Most tumors have multiple mutations, and it is often not clear which one to target to achieve maximal benefit clinically. Once a gene is mutated, it can lead to the activation of multiple pathways, resulting in disease progression and potentially requiring several interventions. Therefore, NCI's IMPACT trial is designed to determine whether people with specific mutations will benefit from a specifically chosen targeted intervention, and if these interventions lead to better outcomes. So I just want to end by talking about some of the clinical trials that we have in the Center for Cancer Research Women's Malignancies branch. So immunotherapy is definitely at the forefront of cancer treatment, and breast cancer is also among those that are amenable to immunotherapy. The PD1, PDL1 pathway is a very prominent area of research right now. So PD1 receptors are expressed on T cells and macrophages, and PDL1, the ligand, is upregulated on certain cancer cells, including breast cancer cells. When they interact, it actually dampens the immune response, causing an upregulation of certain immune suppressor cells. So if we can develop, we have developed many inhibitors to the interaction, it would help, it would upregulate the immune response. So and then PARP inhibitors in breast cancer. So PARP inhibitors, they inhibit PARP1 and 2, and when you use PARP inhibitors in cells that already have an inherently damaged DNA repair process, such as triple-negative breast cancer, you're going to get accumulation of damaged DNA and eventually cell death. So that is the area where we would like to use it. Triple-negative breast cancers already have BRCA mutations, P53 mutations. They have already an inherently damaged DNA repair process, and then when you block the final repair process that is available to them, you will accumulate damaged DNA and cause apoptosis. So what is the preclinical rationale for combining PARP inhibitors with PD1, PDL1 inhibitors? So preclinical studies have shown that PARP inhibitors upregulated PDL1 expression in breast cancer cell lines in animal models. PARP inhibitors dampened anti-cancer immunity via upregulation of PDL1 and subsequently blockade of PDL1 resensitized PARP inhibitor treated cells to T cell killing. And the combination of PARP inhibitors and anti-PDL1 therapy increased the therapeutic efficacy in vivo compared to either agent alone. So in our clinic, we have a trial looking at MEDI14736, which is now known as durvalumab, along with olaparib, which durvalumab is a PDL1 inhibitor. Olaparib, as you know, is a PARP inhibitor. And we're looking at the combination in recurrent triple-negative breast cancer. It's a phase 2 study. We're looking at 2 cohorts of patients with BRCA wild type and BRCA mutated. And our primary endpoint is response rate. We're also looking at duration of response and progression-free survival, overall survival, and toxicity. So this clinical trial is currently open and it's accruing. So check inhibitors. So checkpoint kinases 1 and 2 are cell cycle regulators. They are associated with cellular response to DNA damage and repair. Check 1 and 2 also serve to halt the cell cycle to allow for DNA repair. And so once again, cells that have inherent defects in DNA repair pathways will accumulate damaged DNA and eventually die if check 1 and 2 are inhibited. So we are looking at check 1 and 2 inhibitors in ovarian cancer also, but for our purposes here for this lecture, also in metastatic triple-negative breast cancer. So the cohort that is currently open is in BRCA wild type, although we have already finished a cohort in BRCA mutated, in which you would expect it to be actually more effective because of the BRCA mutation. Our primary endpoint is response rate, and we're looking at a duration of response, progression-free survival, overall survival, and toxicity. So the patients continue to receive this agent. So 1 cycle is 28 days. They receive it on days 1 and 14, so it's twice in a cycle that they receive this agent. Some of the cytotoxicities that we have seen, it'll drop the blood counts, and that's the major thing is we see anemias, cytopenias. We have to give Neulasta to keep the blood counts up. So that's the major side effects that we've seen. The patients get imaging every 2 cycles, and we look for either stability or progressive disease using the RECIST criteria. And the patients will continue on, or not just this trial, but any of the trials that I talk about. We use RECIST criteria, we use imaging, and the patients continue unless they progress. So a progression would be defined as 20%. We identify target lesions when we do clinical trials, and we follow those target lesions to see if they are getting larger or smaller. So anything 20% larger than baseline would be considered progression. If it regresses by 30%, that is, we call that a PR, a partial response. If it completely disappears, it's a CR, complete response. So this is open and accruing, this trial. All right, so another trial we have is based on this agent TDM1. It's a novel HER2-directed antibody drug conjugate, as I spoke about before. It's trastuzumab conjugated to the cytotoxic chemoimantacine. So basically, its cell kill method is twofold. The trastuzumab actually retains its ADCC action and its inhibition of HER2-mediated signal transduction, and also there's targeted delivery of the cytotoxic chemotherapy to the HER2 new positive cell. So it binds to the extracellular domain of HER2, then it's internalized into the lysosomes, then it's proteolytically degraded, releasing the lysine MCC DM1 into the cytoplasm, and ultimately it inhibits microtubule polymerization. So that's the main action, along with, I already said, the ADCC that's kept intact. So in our clinic, we have a phase 1/2 study of using this agent either alone or along with temozolomide in the secondary prevention of HER2-positive breast cancer brain metastases following stereotactic radiosurgery. So these patients have HER2-positive breast cancer. They have already had brain metastases. They've had their brain metastases treated by stereotactic radiosurgery, and now we are giving them temozolomide, which is an approved chemotherapeutic for glioblastoma, glioblastoma, which is a brain cancer. So temozolomide along with this agent. So I mean, usually we think that there's no, we have a blood-brain barrier, and it's very difficult to have chemotherapeutics cross the blood-brain barrier. But recently, research is showing that in metastatic disease, there's a disruption of this blood-brain barrier, and molecules, certain larger molecules such as TDM1, can cross the blood-brain barrier. So this is a new study. We have not accrued any patients on it yet. It just opened, and it's let's see, we're looking basically at safety and response. So. Okay, so another study that we have in our clinic, it's ONC201 is a small molecule originally identified as a trail-inducing compound, currently being tested in phase 1 and 2 clinical trials in multiple cancer types. So you may be familiar with this compound. It's gone through multiple phase 1 and 2 studies that have been reported. 2 recent studies reported that ONC201 also induces an atypical stress response mediated in part by ATF4 and CHOP. In the lab, so all of the research is done in Dr. Lipkowitz's lab here in CCR, and they tested the effects of ONC201 on 18 human breast cancer cell lines that represented the spectrum of all breast cancer cell types, and found that the viability was reduced in all subtypes that were tested. So unexpectedly, what the Dr. Lipkowitz lab discovered was that ONC201 toxicity was not dependent on trail receptors or caspases, which they had originally thought, but live cell imaging revealed that ONC201 caused cell membrane ballooning followed by rupture. So ONC201 also induced what they found, phosphorylation of AMP-dependent kinase and depletion of cellular ATP in multiple breast cancer cell lines, as well as inhibiting mitochondrial oxygen consumption, but not glycolysis. ONC201 also induced toxicity and ATP depletion, and that was enhanced in non-glucose medium and reversed when glucose was supplied. So basically, ONC201 causes ATP depletion, it causes induction of phospho-AMPK, ATF4, and CHOP, ultimately resulting in disruption of mitochondrial morphology and inhibition of respiration and cell death. So this is definitely translational research that's coming out of our laboratory and into the clinic. We have a phase 2. We are going to open this trial very shortly. Phase 2 for metastatic breast and endometrial cancer using ONC201. The phase 1 trials have been done in other cancer types. So we have a recommended phase 2 dose. And so that we're starting at the phase 2 level. So we're using 3 cohorts. Cohort 1, hormone receptor positive breast cancer. Cohort 2, triple negative breast cancer. And cohort 3 is endometrial cancer. Our primary endpoints are basically objective response rate and safety. And so this trial is currently pending IND and final IRB approval, and it should open shortly. What else can I tell you? So we require biopsiable disease for most of our studies because we use those for research purposes, looking at correlative studies once the clinical trial is completed. So this is my last slide, and I just want to say, we will continue to use our rapidly increasing knowledge in the fields of cancer genomics and cell biology to identify actionable mutations, establish biomarkers of response and treatment, and use that knowledge to more effectively treat our patients, identifying those who are more likely to recur, sparing the toxicity of chemo for those women at low risk of recurrence. And these are the most important things in breast cancer today.
Any questions for Farah?
Are those increased hormones, due to, say, early puberty or late menopause, are those only associated with increased risk of PR-positive breast cancer, or are they associated with increased risk of all breast cancer types?
Well, you would assume that it would be due to more than likely it would be hormone receptor, but I don't know if in women later in life, I mean, you can have changes. You can start off with a hormone receptor positive breast cancer. It can convert to, that's why we do biopsies later on, because when cancer metastasizes, you can have actually a very different profile.
Right.
So, yes.
Also, there's also says, if you have family members who've had breast cancer, or like this number of family members who had breast cancer before age or before menopause, you have an increased risk of breast cancer by some percent. What percentage of those cancers are associated with BRCA mutations? Is it most of them, or
If it's due to BRCA, more than likely the family member will also have a BRCA mutation, and that is the cause of the breast cancer.
Right, you answered the converse.
Yeah.
No.
You were saying that if you have a BRCA,
I said if you have a cancer that occurs before menopause, how likely is that to be a BRCA mutation associated with cancer? Not if you have BRCA mutation.
We know that women who are diagnosed earlier in life are more likely to have a more aggressive form of cancer, and they are more likely to have a BRCA mutation. Those aggressive forms are diagnosed for women who are younger than 40, and more than likely they have P53 mutations, BRCA mutations. So the earlier you are diagnosed, the more aggressive the cancer usually, and the more likelihood of having BRCA mutations and other mutations.
So it looks when you're looking at this compound, because its effects are not mediated by trailer caspase. Where is the actual selectivity for cancer cells in that, or is it just that cancer cells have a higher usage of ATP? Because, like, I guess you didn't go into great detail with it, but if it's just basically swelling, how does that show selectivity for cancer cells? Or is this just sort of a dose dependent?
Since I'm not in the laboratory, I don't know if I can completely answer that question. But I mean, it causes cell death. It causes apoptosis. So I don't know how I can further up.
Right. I'm saying like the download of both cancer cells and normal cells. But that's not a very good picture.
Okay, we should be moving on.
Okay.
Thank you, Farah.
You're welcome.
The next speaker is Haobin Chen. He's an assistant clinical investigator in the thoracic and gastrointestinal oncology branch. He got his MD from Shanghai Medical University in China, and then a Ph.D. from New York University. He was a research assistant professor at NYU for 4 years, and then did a medical residency in New York. He joined the NCI Medical Oncology branch as a clinical fellow in 2013. He's going to talk to us today about small cell lung cancer. Haobin.
All right. Thank you so much, Terry, for the kind introduction. You know, about 4 years ago, I was sitting in the same room as you do now. But welcome to the course. So today, actually, I'm going to talk about a small cell lung cancer. And here is the outline of my today's presentation. So I will first talk about give you an overview of the clinical management of the small cell lung cancer, and also talk about some of the challenges that we are facing. And after that, I will talk about the biology of the small cell lung cancer, and also give you some of the examples about the translational research in this cancer type. All right, so let's start. So why is it called a small cell lung cancer? As you may have already figured out from the name, you know, that's because of the size of the tumor cells, you know, is smaller than the cells of other histology type of lung cancer. So here is an H&E staining of the small cell lung cancer, and the arrow point out the small cell lung cancer, and those are in morphology resemble the old grain with the very prominent the nuclei and the scanty cytoplasm. So in comparison, it's just a little bit bigger than the lymphocytes, which was pointed by the arrowhead. So the small cell lung cancer only accounts about 10 to 15% of all lung cancer. And this is also a smoker-related disease. And based on the histology type, lung cancer can be classified as the lung adenocarcinoma, squamous cell carcinoma, large cell carcinoma, as well as the small cell lung cancer. The former three are sometimes grouped as a non-small cell lung cancer. The reason why small cell lung cancer is singled out is because it has a very different clinical presentation, and also its prognosis is also much poorer. And just to give you some of the examples, at the time of the diagnosis, the small cell lung cancer has often metastasized to the other side. And the small cell lung cancer is also often associated with a syndrome called the paraneoplastic syndrome. Why it's called paraneoplastic syndrome is because a set of signs and the symptoms is caused by the tumors that's far away from the affected organ system. For instance, a set of small cell lung cancer cells can excrete ACTH, and ACTH can act on the adrenal gland and induce the expression of the cortisol and leads to the Cushing syndrome. And the other interesting syndrome is called the Lambert-Eaton myasthenic syndrome. So the presence of the small cell lung cancer can sometimes trigger the production of an antibody that can target the calcium channel at the presynaptic membrane. And the presence of this antibody can actually block the calcium channel so that it can affect the release of the neurotransmitter. And as a consequence, it can lead to the muscle weakness. The presence of the paraneoplastic syndrome and sometimes can occur way in advance of the detection of the cancer, and can also increase the complexity of the clinical management. The small cell lung cancer is actually a recalcitrant cancer. So far, there's only two recalcitrant cancers. Small cell lung cancer is one, and the pancreatic cancer is the other one. So here are the definition for the recalcitrant cancer. So the cancer need to have a 5-year relative survival rate of less than 20%. In the case of a small cell lung cancer, it's less than 7%. And the cancer also need to, cause the death at least 30,000 people in the United States each year. In the case of a small cell lung cancer, it's roughly about 30,000 deaths each year caused by the small cell lung cancer. The National Cancer Institute actually identified 4 major obstacles for the major breakthrough in the small cell lung cancer in 2014. So the first major obstacle is that even after smoking cessation, patients are at risk of developing the small cell lung cancer. As you probably have heard that the low-dose CT screen can actually detect, early-stage non-small cell lung cancer, actually can improve the survival of these patients. But this is not in the case of small cell lung cancer because this tumor type is so aggressive. And at the time when you detect the tumor, patient has already had sometimes metastatic disease. So there's no effective screen methods to detect small cell lung cancer at a really early stage. And we also mentioned about a second obstacle that most of patients already had widely metastatic tumors at the time of the diagnosis. And the third obstacle is that these tumors tend to develop a resistance very quickly. And there's only 2 lines of chemotherapies that are considered as a standard of care therapy for small cell lung cancer. So once a patient develops a chemo resistance, and the second line chemotherapy is also not very effective. So patient will exhaust all the treatment options very quickly. And the fourth obstacle is that there's no enough tumor tissues for the research in the case of small cell lung cancer. The reason is that surgery does not play a role in the treatment of a small cell lung cancer. So therefore, you don't really have too many patients' tissues for research. So the staging of the small cell lung cancer is relatively simple. So there's only 2 stages. The 2-stage system is more widely used. So if the tumors can be included in one radiotherapy port, so then it's considered as a limited disease small cell lung cancer. And the treatment includes both the systemic chemotherapy and the radiation therapy. The estimated overall survival over this group of patients is about 1.5 years, roughly. So if the patient's disease cannot be included in just one radiotherapy port, then it's considered as an extensive disease. And the systemic chemotherapy is only the treatment modality for this group of tumors. And the median overall survival is usually less than 1 year. Back in 1970s, it was recognized that the combination chemotherapy is actually more effective than the single-agent chemotherapy. So in the early 1980s, the platinum and the etoposide doublet has established its role as the first-line chemotherapy for the small cell lung cancer. Unfortunately, in the last 40 years, this hasn't really changed. So this is still the first-line chemotherapy. And based on the patient's, response to the chemotherapy, you can divide the patient as the tumors as a sensitive disease or refractory disease. So this is purely based on whether the relapse occur within or after 3 months after completion of the chemotherapy. The only FDA-approved second-line chemotherapy is topotecan. And in the patients with a sensitive disease, the response rate is about 20 to 25%. But in the patient with refractory disease, the response rate is only about 5%. So these are only two standard of care chemotherapies for the small cell lung cancer. So small cell lung cancer tends to metastasize to other places, and the brain is a very common site. The reason is that the brain is a sanctuary site, and the chemotherapy, cannot really penetrate the blood-brain barrier and get into the brain. So at the time when patients have a relapse, the brain metastasis is very common, and brain metastasis is also pretty difficult to treat. So back in the 1980s, so the prophylactic cranial irradiation was tested, and based on the meta-analysis, it seems like the PCI, prophylactic cranial irradiation, can actually improve the patient's survival. So in 2007, we finally had a result from a phase 3 trial, and the data actually was shown on the right side. So these are the group of patients who had a response from the first-line chemotherapy. So regardless whether they have a brain mass or not, because those patients didn't really get MRI at the time, so they actually will receive a prophylactic cranial irradiation or not. So by comparing these two groups, it was found that a patient who received the PCI actually had a better overall survival. And this actually helped to establish that PCI is a standard of care in the patients who actually had a response to the first-line chemotherapy. All right. It's the entire brain, whole brain, yes.
What are the side effects?
The side effects can include the decrease of cognition and memory issues, and usually that's a common side effects. It can improve over time, but sometimes it won't really improve to the baseline. Yeah. So actually, this question leads to a very good it's a study question studied by a group of Japanese physicians. So because the prophylactic cranial irradiation is not really benign because it can cause all these kind of side effects. So whether it's really necessary to irradiate all the patients who had a response, or we should just choose a patient who had a brain metastasis at the time when they completed the first-line chemotherapy. So in this trial, they actually select patients who had a response to the first-line chemotherapy. And then they did an MRI and selected a group of patients who did not have brain metastases on the MRI. And then they randomized them to either the PCI group or just a control group. Actually, what they found is actually quite different from the previous study. So the panel A actually showed the overall survival. As you can see that the patient who received the PCI actually had a little bit worse overall survival compared to the control group. And in the panel B, show the percentage of the patients with the brain metastases. And as expected, the prophylactic cranial irradiation actually decreased the incidence of the brain mets. But this decrease of overall survival in the patients who received the PCI is likely due to the side effects of irradiation. But right now, this is only tested in the Japanese population. It hasn't really been confirmed in the US population. So that's why this is still not considered as a standard of care treatment. All right, so next I'm just going to change the gear and talk about the genetic abnormality of the small cell lung cancer. So it actually was recognized very early that small cell lung cancer harbors many genetic abnormalities. this deletion of a chromosome 3p21 actually was recognized back in 1980s. So on the left side actually show the staining of the metaphase chromosomes of 5 different small cell lung cancer cell lines derived from the patient. And the common thing is that they all had a deletion of chromosome 3p21. Actually, the deletion of a 3p21 is not very specific because it has also been observed in the patients with other type of lung cancer, as well as in the patients with the cervical lesions. And the chromosome 3p actually have a number of candidate tumor suppressor genes, such as BAP1, BAP1, and RASF1. Until this date, it's still not clear which tumor suppressor genes in the chromosome 3p21 play an important role in the tumorigenesis of the small cell lung cancer. During the meantime, it was also found that chromosome 13q and chromosome 17p also, commonly have the abnormality in the small cell lung cancer. Back in the 1980s, it was recognized that the RB tumor suppressor gene, retinoblastoma gene, actually was located in the chromosome 13q, and the other tumor suppressor genes, TP53, is located in the chromosome 17p. So Dr. Frederick Kay from the NCI actually asked this question, whether RB is affected in the small cell lung cancer. And here is the northern blot data he did published in the science paper in 1988. So what he found was that in the small cell lung cancer, oftentimes you can find either loss or the decreased expression of the RB. So he actually did the confirmation test and found that in more cell in these 12 additional cell lines, only one cell line had expression of the RB, or others had a loss of the RB expression. During the meantime, John Manner actually asked a similar kind of questions. He actually was testing whether P53 is lost in the small cell lung cancer as well as the non-small cell lung cancer. And here is a table to summarize his finding. So basically, he found that P53 is commonly lost or mutated in the small cell lung cancer as well as non-small cell lung cancer. And just want to point out that some of the tumors, non-small cell lung cancer cell line, as well as the small cell lung cancer cell line, that he initially didn't detect a mutation, was actually proved to have a mutation in P53 genes. All right, so the previous two studies just established the connection between the loss of RB and P53, but didn't prove the cause relationship. So this actually was proved by the Dr. Anton Burns in the Netherlands. So what he did was he used a conditional knockout to eliminate RB and P53 genes in the lung epithelium in a mouse model. So after 2 months, he actually observed these hypoplastic lesions in the airway of the knockout mouse. And as you can see here, this is a BRDU staining. So these lesions are highly proliferative. So if you waited long enough, after 6 months, you started to see the appearance of the small cell lung cancer in this mouse model. He actually later tried the combination of P53 RB knockout and overexpression of a MYC or LMYC. He actually was able to greatly accelerate the generation of the small cell lung cancer in this mouse model. So the importance of RB and P53 gene inactivation was also demonstrated in another very rare clinical scenarios. So some of the patients who actually started with non-small cell lung cancer with the EGFR activating mutations, but if you treat those patients with the tyrosine kinase inhibitors such as erlotinib, a part of these patients can actually develop a small cell lung cancer. And here is the report on this phenomenon. So this actually is the medical history of one patient. So the patient was diagnosed of the EGFR mutated the non-small cell lung cancer in 2008 and was treated with erlotinib for a year and then developed this small cell lung cancer. And the patient was then treated with chemoradiation therapy and then was put back on the erlotinib. And eventually the patient developed the chemo resistance and also resistant to the erlotinib and eventually expired. At the time when they look at the metastases he had at the autopsy, actually what they found was that in the normal liver, so the patient had a white type P53. In the lung adenocarcinoma, patient had a loss of one copy of P53. But in the two small cell lung cancer found in this patient had the biallele loss of P53. And this group of researchers also look at the level of RB by using the immunohistochemical stainings. So here they include in total 19 patients. And the very interesting contrast is that, in the same patient, when the patient has adeno, so there's a positive expression of RB. But when it's a neuroendocrine tumor, such represents the small cell lung cancer, then the RB expression is inactive, not detectable. Again, this point out that the loss of RB and the P53 are important for the tumor genesis of the small cell lung cancer. So now we are in the genomic era. So there also has been quite a lot of efforts to really define the genomic architecture of the small cell lung cancer. So this is actually the mutation data from one of the largest studies on the small cell lung cancer. And as expected, so the RB and the P53s are mutated in like over 90% of the patients. And the study also identifies several other group of genes that are very frequently mutated. So one group of genes are related to the epigenetics. So EP300 and the CREB-BP are the histone acetyltransferase. Those are mutated in about 15% of patients. And the other group of genes that are often mutated are Notch receptors. So Notch 1, 2, 3, and 4. And if you look at here, so those mutations are actually mutually exclusive. And on the right-hand side, which shows the change of the gene copy numbers, the red means the amplification, and the blue represent the deletion. So in the small cell lung cancer, oftentimes you can find the amplification of MYC family genes, such as MYC, LMYC, and NMYC. So IRS2 is a gene involved in the PI3K signaling pathway. So this was also seen to be amplified. So the RB, P53, and P16 are often mutated in, are deleted in the small cell lung cancer. So here is just to summarize what are the common pathways affected in the small cell lung cancer. So both P53 and RB are involved in the cell cycle regulation. And the PI3 kinase is also often affected in the small cell lung cancer. 9% of patients have loss of PTEN, and also there's an activating mutation of a KIT and amplification of IRS2 that can activate the PI3K signaling. The epigenetic enzyme and also MYC are related to the transcriptional regulation. And the fourth group of genes that are affected are the notch signaling. And I will talk more about this pathway in the next few slides. So as I mentioned earlier, that one of the big problems of the small cell lung cancer is that it metastasizes at a very early stage. In the 2016, actually, one of the genes was found to be related to cause the metastasis in the small cell lung cancer. So this gene actually was found in the mouse study. So when the researchers look at the liver metastases, they often find that this gene called the NFIP was amplified in the liver metastases, but not in the primary tumor site. So in the 2016 Cell paper, actually the function of this gene was discussed. So this gene actually is a transcriptional factor. It can actually lead to the activation of the neuronal genes. So that can affect the cell motility as well as affect the cell and cell adhesion. So all these are related to the cell metastases. But so far, we don't really have any good method or a good way to target this gene amplification. All right, so next I'm just going to give you some of the successful examples of translational research in the small cell lung cancer. The first is about the story of the rover T. So here is the cartoon is showing the cascade of the notch signaling. So notch is actually a membrane receptor. So when it's bound to its ligand, as shown here, so those can be activating or antagonizing ligands. So when it's bound to the activating ligands, actually the notch receptor will have a conformation change. And then it's sensitive to the effect of the gamma secretase. The gamma secretase can cleave the notch receptor, and the intracellular domain of the notch receptor can then migrate into the nucleus. So inside the nucleus, this intracellular domain can bind to the transcriptional factors and activate the gene transcription. So as I mentioned earlier, that in the genomic studies, it was found that the notch receptors are often mutated. So it suggests that the downregulation of the notch signaling is important for the tumorigenesis of the small cell lung cancer. So to study about the significance of the notch signaling, so a group of researchers actually did overexpression of the Notch2 intracellular domain in a transgenic mouse model. And what they found is that the ectopic expression of Notch2 intracellular domain, which represent the turning on of the notch signaling, actually can decrease the number of the small cell lung cancer in the P53 and RB knockout mouse model. So here are the pictures showing decreased number of the small cell lung cancer in the lungs, and here shows the quantification. And the mice who has the constitutively notch signaling on also have a better survival, as shown in the black curve here, compared to the one that does not have the notch signaling on. So as shown in the previous table, so only a portion of the patients have mutations on the notch receptor. So what happened to the rest of the tumors? Because if the notch signaling need to be turned off to generate the small cell lung cancer. Actually, it was found that small cell lung cancer have the overexpression of one of the notch ligands called the DLL3. the DLL3 is actually a ligand that can antagonize the Notch signaling, meaning that if you have a high expression of a DLL3, you actually will turn off the Notch signaling. So here are the RNA-seq data by looking at the DLL3 expression in normal lung compared to the small cell lung cancer patient tissues, as well as small cell lung cancer cell lines. As you can see that the small cell lung cancer tends to have about 80 or 90-fold higher expression of DLL3 compared to the normal lung. So how would you be able to use that information to treat the small cell lung cancer? So what happens is that DLL3 actually is a membrane protein. So you actually, can use an antibody to target such membrane protein. So similar as TDM1 mentioned in the previous the speaker. So the scientists from the Stemcentrx now is a part of the AbbVie. They developed this antibody drug conjugate. So they have this antibody that can recognize the DLL3. By using a linker, they're able to connect a very toxic chemo agents to this antibody. And this chemo agent is so toxic that it's not used for the systemic chemotherapy. But it actually is very useful in the case of antibody drug conjugate, because only a very small amount of these drugs can actually kill tumor cells. So here are some of the findings they have in the small cell lung cancer PDX models. So the PDX model was actually first treated with the cisplatin and etoposide. That's the standard of care first-line chemotherapy. So there's a shrinkage of the tumors. But once you stop the chemotherapy, the tumors comes back very quickly. And here, they actually give the mouse 3 doses of this robot T antibody drug conjugate. As shown in this red line, you can see that those tumors shrink in size, and actually they didn't really come back, within the next, about 3 months. Those black curve represent the control mice that did not receive the treatment. On the right-hand side, they actually show what if you treat these mice with a second round of chemotherapy. So those are shown in the blue curve. As you can see that, once you give the chemotherapy, the tumor shrinks, but it comes back faster than the first round. So it suggests that these drugs are probably pretty effective. So to test that in the patients, actually these are the results from the phase 1 clinical trial. So here they actually did not differentiate the patients based on the DLL3 expression. So they actually accepted all comers. So they did the dose escalation, and also they look at the DLL3 expression as an exploratory endpoint. So about 67%, that means 2/3 of patients have expression of DLL3 in over 50% of the tumor cells, and 88% of patients have DLL3 expression in greater than 1% of the tumor cells. So here is the waterfall plot, and if this actually show the best response of the patients after the treatment. So if the patients, each bar represents 1 patient. If the bar is below the dotted line here, that means the patient has either a partial response or complete response, as shown in this case. So as you can see from here, most of these patients who had a partial response are green bar, which represent the expression of a DLL3 greater than 50% of the tumor cells. But there's also a couple of patients who had a gray bar, which represent, the not unknown DLL3 expressions. So it appears that, the high expression of a DLL3 is a predicted biomarker of response to this type of drug. but this is expected because DL3 is a target for this antibody drug conjugate. So here, just a list of the overall objective response rate of all the patients here to the this robot T. And in the patients with a high expression of the DL3, actually you have a better response rate. And same is true for the clinical benefit rate. So clinical benefit rate include both the response and such as PR and CR as well as the stable disease. So next is immune therapy. So immune therapy is probably the hottest therapy at this moment in the oncology. So the previous speaker has also kind of give the introduction about the importance of the PD1 and the PDL1. So PD1 and the PDL1 axis is actually a mechanism for your normal cells to stay away from the attack by your own immune system. Because the tumor cells are derived from the normal cells, so it also has the same mechanism to escape the immune surveillance. The checkpoint inhibitors are actually the antibodies that can bind to the PD1 or PDL1 so that it can disrupt the interaction between these two molecules so that it can block the signaling of the PDL1, PD1. All right. Right now, there's no good predictive marker for the response to the immune checkpoint inhibitor. There are several the predictive biomarkers, such as the tumor mutation burden or the PD1 expression. However, none of these biomarkers have a high enough sensitivity to identify all the patients that can potentially benefit from this type of therapy. So that's why none of these has been used. Actually, that's not completely correct, but there's still a research going on to identify a better predictive biomarker. So here is the tumor mutation burdens in about 20 different tumor types. Small cell lung cancer actually have a pretty high tumor mutation burden. This is partially because this is a smoker-related disease, and tobacco can cause quite a lot of mutations in cells. So this actually suggests that the small cell lung cancer may respond well to the immune checkpoint inhibitor. So the other predictive biomarkers that has been suggested is the expression of the PD1 and the PDL1. And here are the stainings of the small cell lung cancer with the PD1 and the PDL1 antibodies. Interestingly, in this study, they actually found that there's no staining of a PD1 and a PDL1 on the small cell lung cancer tumor cells. However, you can see the staining of the PD1 and PDL1 in some of the stromal cells in those slides. So here, just a table to list the findings. So what they found is that the tumor cells did not have the staining of the PD1 and the PDL1. And about 18.5% of patients have a PDL1 staining in the stromal cells. However, I have to mention that these findings is different in different studies because different groups use different antibodies to check for the PDL1 expression, and that leads to the different results. So in this series, the researcher found that about 82% of small cell lung cancer has an expression of the PDL1. So another interesting phenomenon is that the PDL1 gene is amplified in about 1.9% of small cell lung cancer. So on the left-hand side, which showed the overexpression of the the CD274, which is the gene of PDL1 in some of the small cell lung cancer tumors. And this is because of the amplification of the genes. And this actually tends to be tends to affect only very specific regions in the chromosome 9p24. On the right-hand side, show the immunohistochemical staining of the PDL1 in the patients who had the high expression level of CD274. And again, there's a very good correlation between the RNA-seq finding and the immunohistochemical staining findings. So just to summarize these studies findings, so there in a subset of small cell lung cancer patients, they tends to have the expression of the PDL1 or amplification of the PDL1. That suggests that some of the patients may actually benefit from the immune checkpoint inhibitors. So this actually was tested in the clinical trial. So this is the study design of a Checkmate 032 study. So in these studies, patients are randomized to receive either a single agent of nivolumab, which is anti-PD1, or in combination of the ipilimumab, which is the antibody against the CTLA4, another immune target. So here are the combination of different doses of nivolumab and ipilimumab. This is the patient characteristics. Again, they actually accepted all comers, so they didn't really separate patients based on, or select the patients based on the expression level of the PDL1. And again, in this cohort of patients, about 14 to 20% of patients have expression of PDL1 greater than 1%. So here, list the objective response rate in all three different cohorts. So in the nivolumab cohort, about 10% of patients had a partial response. In the drug combination cohorts, about 20% of patients had a response to the treatment. And on the right-hand side, here shows the spider plot. So what I want to point to your attention is that some of the patients have a pretty durable response on the immune therapies. How about the toxicity? This is actually the combination treatment are not so benign. Some of the patients actually died from the treatment, and also there's a pretty high incidence of immune-related AEs, such as pneumonitis and the limbic encephalitis. All right, so this actually is the most recent data. So they actually look at the expression level of the PDL1 and then examine the response rate in the different group of patients with a different level of the PDL1 with a tumor mutation burden. So what they found is that in the patient with a high tumor mutation burden, actually there's a higher response rate to single agent as well as to the combination. So for the all-comers, the response rate to the nivolumab is about 10%. But in the patient with a high tumor mutation burden, the response rate doubled. And this is true for the combination treatment as well. And as expected, the patients with a lower tumor mutation burden actually had a less response rate. Actually, there's also several other promising agents that are currently under the clinical trial. So such as WEE1 inhibitor and also ATR inhibitors. And NCI CCR actually has the several clinical protocols to test these agents in a different type of the tumors. All right, so in the last couple of slides, I just want to point out a very useful resource for anyone who is interested in the study of small cell lung cancer. And Beverly Teicher at NCI Frederick actually did a number of high throughput screening in 63 small cell lung cancer cell lines by using a library that contains 564 the FDA approved drugs as well as investigational agents. It's very disappointing that she found that none of the drugs can have the sensitivity in all the small cell lung cancer cell lines that she has tested, which suggests that small cell lung cancer is a very heterogeneous group of the tumors, and some are sensitive to one type of drugs, but not to it's not true in some other cells. So here, just an example of the tumor cell line response, IC50, to the etoposide, which is the first-line chemo agent for the small cell lung cancer. As you can see that some are quite sensitive, but some are quite resistant as well. So what you can find useful is that she actually included the gene expression data of all 63 cell lines, and as well as their IC50 values of these cell lines to all different 564 the FDA-approved agents, as well as the investigational drugs. So in the last one slide, I want to point out about the extrapulmonary small cell carcinoma. So compared to the small cell lung cancer, the extrapulmonary small cell carcinoma is actually quite rare. And so because it's so rare, so there's no the clinical trial on this tumor type. So the first line systemic chemotherapy is actually borrowed from the small cell lung cancer. So it's the platinum and the etoposide doublet. And what's different between small cell lung cancer and the extrapulmonary small cell lung cancer is the rate of the brain metastases. And the majority of the extrapulmonary small cell lung cancer, except the prostate and the head and neck, the small cell carcinoma, tend not to metastasize to the brain. So for the patients who has an extrapulmonary small cell carcinoma, which was not located in the prostate or head and neck, the prophylactic cranial irradiation may not be necessary. All right, just to summarize, the small cell lung cancer is a recalcitrant cancer, and the neurotherapy is urgently needed. So we mentioned that the p53 and RB inactivation are actually pretty common in the small cell lung cancer. So some of the new therapies are emergent, such as the Rover-T antibody drug conjugate, as well as the immune therapy with the immune checkpoint inhibitors. All right, thank you for your attention, and I will take some questions. That's a very good question. So this actually is a hot topic that has been studied. So for the small cell lung cancer, it's the immune therapy is still relatively new, so this hasn't been reported. But in other tumor types, such as the melanoma, which immune therapy has started pretty early, so this has been studied quite a lot. So if you have attended the immune therapy symposium that was held in NCI a couple of weeks ago, actually some of the speakers kind of talked about that. So such as the JAK1/2 signaling pathway activation and so on. So those could be some of the mechanisms for the cells to develop resistance to the anti-PDL1 type of drugs.
So in addition to antagonistic ligands of notch, such as TLC, there are activating ligands. Has anyone tried creating sort of a mimetic of the activating activating ligands as much?
To my knowledge, no one has tried that. The reason is that if you look at in other tumor types, actually notch signaling is considered to be essential for the maintaining of the stem cells, and if you believe so, also cancer stem cells. So this could be a double-edged sword. So by activating notch signaling, in the whole body, may actually cause unnecessary toxicity. But
Well, your DLL3 antibody isn't administered systemically because it's too toxic. So you could have a which you have a more localized administration.
yeah, so I think selectivity would be a key. How would you be able to just target the small cell lung cancer, not to the other organ in the body? Yeah.
Okay, and then also, I didn't fully follow. Do you understand the mechanism by which EGFR inhibition leads to conversion to small cell lung cancer? So, like erlotinib, you said that that it's been observed that
Yes.
people can develop small cell lung cancer following erlotinib. Do you understand sort of the molecular basis for that, or?
I think so far, I think it hasn't been really reported about why this is the case. But what I think is that when you suppress the EGFR signaling, so basically you are putting a selection pressure on the cancer cells. So that it could be a random mutations or some other mechanism that kind of just select the cells that can rely on other signaling to survive. And just this happens that when you have both a P53 and RB mutation, it tends to lead to the development of the small cell lung cancer.
Could just be a field effect.
It could be, yeah. That could also be.
Okay, Haobin, that'll do it. Thank you.
All right, thank you. Yeah, have a good afternoon. Thanks.